Hello. Hello. Okay, you guys, can we come back together, please? Plenty of seats down front. Please come down front. The challenge of getting processed. Okay, so let's go ahead and start again. If those of you that are in the room can go ahead and please take your seat. Maybe we'll get the others in. You have the clicker? Okay, perfect. Okay, we're going to go ahead and start with our next keynote speaker. Just a little bit of an overview where we're going to go. Our next speaker will visit with us for about the next 45 minutes or so, and we'll take time for a question and answer. And then just prior to lunch, we'll go into a brief discussion and presentation by our partners who are running the SBIRT grant. They'll talk a little bit about what that is, and then we'll go into our lunch period. But as we get started with our second keynote speaker, we are particularly excited about his talk. Dr. Leighton Huey is visiting with us from the University of Connecticut. He has enjoyed a long career of training students, psychiatric students, mental health students, to provide care to a range of patient populations. Dr. Huey will share with us a little bit about the work he's been doing. We're especially excited about his talk because he's a leader in healthcare reform, and as our nation is continuing to tackle the topic of healthcare reform, the information that he provides to us will be especially relevant. You have his bio in your packet, but I just wanted to highlight a little bit about his background. Currently, Dr. Huey is the Associate Dean for Community and Continuing Medical Education at the University of Connecticut School of Medicine. His MD is from the Albany Medical College at Union University, and he spent time doing his residency in the Department of Psychiatry at the University of California, San Diego. Please welcome to the stage Dr. Leighton Huey.
Well, thank you, Ramona, and thank you, Sarah, for your hospitality for my visit here. So if I give a lousy talk, can I blame it on the microphone? Okay, good. So I see a lot of millennials here, and so I'm going to say I come from the generation of people where we've said people over 30 can't be trusted. So sorry, millennials and Sanders people, we got there first.
The mic's not working.
So in my more disgruntled days, and fortunately I don't have very many of them, I think that the entire workforce and administrators and politicians should die off. Should die off. I kind of croaked when I said that. Because, and we should just start all over, but knowing that that's not going to happen, I have to be content with the concept of incremental reform and all the painstaking work and the problems and the snafus that go along with that. So I want to start with a perspective that anybody can relate to. If other industries were like healthcare, if banking were like healthcare, automated teller machine transactions would not take seconds, but perhaps days or longer as a result of unavailable or misplaced records. If home building were like healthcare, Carpenters, electricians, and plumbers each would work with different blueprints with very little coordination. If shopping were like healthcare, product prices would not be posted, and the price charged would vary widely within the same store, depending on the source of payment. If automobile manufacturing were like healthcare, warranties for cars that require manufacturers to pay for defects would not exist. As a result, few factories would seek to monitor and improve production line performance and product quality. And finally, if airline travel were like healthcare, each pilot would be free to design his or her own pre-flight safety check or not perform one at all. So that's led me to conclude that healthcare sucks. It's in silos, it's uncoordinated, the costs are unfathomable, the knowledge base is frequently outdated, and the system is fragmented. So your laughter tells me that you really know this already. Now, what's the basis for my disgruntlement? Well, this is from the 2014 Commonwealth Fund study. And take a look at the 12 countries that are represented there, which are industrialized countries in the world. And if you look at where the US ranks, it ranks at the bottom in terms of overall quality of healthcare and overall ranking. We think that Canada is really good, but it has its problems too. But the US spends more, we know these data. So there's a lot that needs to be done. And the US has ranked last since this study was performed in 2004. So this is 2004, these are 2014 data. Very arresting data. And the motivating challenges, which is why you are here and why the Lindsay Institute has established this forum, is care that is important is often not delivered. Care that is delivered is often not important. And improving the return on our healthcare investment is an imperative that will require quickening our efforts to position evidence development and application as natural outgrowths of clinical care, to foster healthcare that learns. This is a learning institution. The community is a learning community. And this whole concept of a learning healthcare system is on the front burner of a number of influential systems and think tanks around the country. Now, this is how healthcare should be, in contrast to the earlier slide. Records would be immediately updated and available for use by patients. Care delivered would be care proven reliable at the core and tailored at the margins. Patient and family needs and preferences would be a central part of the decision process. All team members would be fully informed in real time about each other's activities. Payment incentives would be structured to reward outcomes and value, not volume. Errors would be promptly identified and corrected, and results would be routinely captured and used for continuous improvement. That's what we want to have the end product be. And we are very far from that. And I'm not going to go through this but this is the IOM, Institute of Medicine, now called the National Academy of Medicine, Roundtable on Value and Science-Driven Healthcare. And they start with the vision, which is we seek the development of a learning health system which process and copies, and you can read the rest of it. We are here. That's where we are. And we have pieces of things that are happening in terms of vision and characteristics and transformation topics and so forth, but the ultimate goal is to get up here. which our outcomes are with lives saved, health gain, people satisfied, the right care for the right price, efficiently delivered. That's the goal. And listening to the panel discussion this morning, I was struck by the good comments that were being made, and it was like, well, the good comments were down here still because of the fragmentation of the system and all the issues and the problems that go into making the condition of the healthcare system that we have today. So I want to share with you something else from the Commonwealth Fund. These are 2016 data, and they do this every year, which is a scorecard on local health systems, national. So you can see the scorecard ranking for 2016. The top quintile, New England, Upper Midwest, areas in California, the Seattle area. But look at this. Now, what do they base this on? Here are the top 10 healthcare areas. These are not, they list cities, but these are regions, so there can be overlap with across state boundaries in some cases. The top 10 out of 306 areas of the country, Honolulu is number one, and they're judging overall performance based on access, prevention, and treatment, avoidable hospital use and cost, and healthy lives. So there are 3 from California in there, 4 from Minnesota, 1 from Iowa. Now, I wanted to show you, this is where Reno ranks in these areas, and this is where Las Vegas ranks. You read these for yourselves. And part of a learning health system is to take the data and not be afraid of it. To take the data and wrestle with the data and make the changes that are needed to make improvement. You don't shy away from it. You look at it in the face and you say, we have issues and we have problems in these areas. So I know it sounds as though I'm going to slam everything this morning. I don't really intend to be the sole focus of my talk. I'm going to get to some optimistic things a little bit later. But we know that there's a shared accountability that's required and necessary for us to reach the vision and the goal, which is an integration of physical health, behavioral health, and community health. We also know that the healthcare system engages with patients and families just as the socio-ecological environment engages with patients and families, and the importance of the social determinants of health is clear. And I'm going to say something more about that a little bit later. And then we have outcomes. Now I want to go into general healthcare for a moment and talk about some of the people and ideas that have influenced my thinking on this. The first is Paul Starr, who wrote The Social Transformation of American Medicine, which won the Pulitzer Prize in the 80s. And I love his first sentence. The dream of reason did not take power into account. And for those of you who have read this, or for those of you who may want to read it, he takes the development of healthcare from the 19th century through the 20th century and all the developments and dynamics that have influenced the way the healthcare system is today. Another leader is Atul Gawande, whom many of you will be familiar with, the guy with the checklists. I was fortunate enough to hear a talk that he gave some years ago. He said, you know, as doctors, we were trained to be cowboys. So again, this is another desert Western metaphor. We were trained to be cowboys. We could ride in and we could do whatever the hell we wanted to do. and that was it. But really what we need now, we need to be members of pit crews. Everybody has a function that's important. And so that gets into workforce issues. Another work that has influenced my thinking is the Educating Physicians report by Molly Cook, which is referred to as the new Flexner report. After 100 years, there are still major problems in the way that we train people. The focus of education is too inpatient-based. The commercial quality of healthcare is eroding kind of professional, the foundation of professions, really, in terms of ethics and professional behavior. And that calls for sweeping reform in the education of physicians. But the reform can be extended to all the disciplines that we're talking about today, including general health care. The Dartmouth Atlas of Healthcare by Jack Wedenberg, a friend and colleague, came out in 1998. And what he and his team showed is that hospitalization rates, surgical choices, and other medical practices vary widely across regions. So medical enrollees in Miami receive twice as many surgical procedures and tests as enrollees in Minnesota when you match, you have matched populations. Surgeons in some regions perform 3 times as many coronary bypass grafts or non-emergency prostate operations as their colleagues in other areas. So there's no medical necessity for these disparities. The elderly who live in Minnesota, where Medicare costs are low, live as long and as well as the elderly in Miami. So there's the geographic issues. And then there's Don Berwick, who in my book is a hero, one of the heroes, and he talked in a very important paper on the matter of eliminating waste in US healthcare. And he broke it into these 6 areas: failures of care delivery, failures of care coordination, overtreatment, administrative complexity, pricing failures, fraud and abuse. And he said, look, we could sustain costs in healthcare if they were kept at this level, but we certainly cannot sustain costs in this healthcare when they're bumping up to 20% of the GDP. So, and of the approximately $3 trillion US healthcare expenditure, the estimate is that about 1/3 could be eliminated without affecting outcomes. Imagine that, 1/3. You can't eliminate all waste in healthcare, but let's suppose you could eliminate half of that, and you would have $500 billion to pour into something. And what is innovative? We talked about, someone raised the question about what can happen in Nevada that would be considered. I think I said Nevada the way Donald Trump said Nevada. What could happen in Nevada that would be innovative, that would attract and retain your workforce? So, triple aim, now some people would say there's quadruple aim, which I'll tell you what that is in a moment, but triple aim is improving the experience of care for the individual, improving the health of populations, and lowering costs. And virtually all healthcare is rallying around that concept, most healthcare. The quadruple aim has added in an important dimension for this audience, which is taking care of the workforce. That's out of UCSF. So for the purposes of this discussion, behavioral health equals, in my mind, mental health and substance use disorders. That was an artificial distinction that was made many years ago for the wrong reasons. And the behavioral health workforce must be competent in both areas if you're going to do a quality job. So what are the failings of the behavioral health system? Well, I've already alluded to the fact that the system is fragmented with past prejudices that continue to simmer. It's not geared to address the need. Training and clinical delivery are not integrated. The financial flow of funds is not integrated. The community is not integrated into what this system is trying to do. And the experience for patients and families is a fragmented experience. The level of understanding and education about navigating the health system is limited. You know, only about 12% of the US population is fully capable of understanding the health system and making their way through the health system. Does that open up a whole new category of people engaged in healthcare, in the provision of healthcare, which are educators that are going to help families and patients understand what it is that's going on? So, historically, it's a segregated system that exists for no other healthcare specialty with poor internal and external communication. The payment systems, I've already said, are highly fragmented and decentralized. Care is not comprehensive or integrated. We've heard the word integration a lot today. 50% of people with chronic medical conditions have co-occurring behavioral health problems, but 80% of these problems remain untreated or inadequately treated in primary and specialty care medical settings. Yes. And clinicians, for those of you who are clinicians are choking on excessive documentation requirements. So we know behavioral health disorders are prevalent. You know, 5 of the top 10 leading causes of disability worldwide are behavioral health disorders. They're highly prevalent with a 1-year prevalence of almost 20% in adults and 13% among youth. Serious behavioral health illness has a past year prevalence of 4% and results in $100 billion annually in expenditures. It's a risk factor for injuries, physical health problems, and is associated with health risk behaviors. And I've already said that behavioral disorders are under-recognized or under-treated. And one point I want to stress, drug overdose is now the #1 cause of injury-related death in the US. So as a population, we make up a little less than 5% of the world's population, but we consume 80% of the world's supply of opiates. We consume 99% of the world's hydrocodone supply. We consume 2/3 of the world's illegal drugs. Now, Medicaid, its budget, pays about 26 to 30% for behavioral health services. As many as 20% of Medicaid beneficiaries has a behavioral health diagnosis, and spending for those with behavioral health disorders is nearly 4 times higher than for those without. There are higher rates of chronic medical conditions, higher frequency of multiple medical conditions, higher rate of premature mortality. Medicaid enrollees with behavioral health diagnoses have an array of physical health needs, including housing and employment problems. In terms of shortages, over half of counties in the U.S. do not have any practicing behavioral health specialists. Turnover rates range from a minimum of 20% per year, and in some cases 70%. The core behavioral health specialty workforce is comprised of multiple disciplines that tend to act independently. Behavioral health disciplines exert only moderate influence on the population focus within educational programs, allowing educational administrators to select areas of emphasis. There's no centralized federal or state direction regarding the training focus within the educational pipeline, so population needs are inadequately addressed. There are inadequate supplies of professionals to serve children, older adults, residents of rural areas, people with substance use disorders, people with severe behavioral health disorders. Of the 24 or 25 million people with substance use disorders, only about 10 or 11% receive assessment and treatment. 35 of 50 states report having any type of workforce development plan, and of the 35, only 6 achieve a high score that reflects a truly comprehensive workforce plan. So there are difficulties, as we've heard earlier, in recruiting and retaining, achieving diversity, and providing adequate training to deliver safe and effective care. The historical separation of services between physical health and behavioral health contribute. The uneven availability of social determinants of health from a community public health perspective is a problem. There's an unevenness of the behavioral health workforce and its fragmentation. And if the concept is integration or coordination or collaboration, how is this achieved? We can say we're going to integrate. We can say we're going to coordinate. We can say we're going to collaborate. But what do we really mean by that? That discussion has yet to occur. Now, workforce credibility. Does the behavioral workforce have it? Well, I'm still in my slamming phase. Acceptance of Medicare and Medicaid by psychiatrists and psychologists. And there's a certain, at least in my community, pride in not accepting insurance. So a resident of mine from some years ago in Connecticut came back. We had rotations going at a very prominent and distinguished healthcare system. And he said on the consult service, he said, well, my supervisor said to me, I asked the supervisor, well, am I going to have to see a lot of Medicaid patients? And the supervisor said, well, you'd be surprised in those days at how many people will pay cash to see you. So the implication was that you don't really have to take people with Medicaid, with public insurance issues. And that gets into some of the kind of debt forgiveness things and stuff like that I'm going to mention in a moment. In the 1990s, costs for behavioral health services were rising at twice the rate of physical health services. That led to the carve-outs. Behavioral health services historically were separated from physical health services, and physical health, in all honesty, has not been interested up until relatively recently. And there's some reasons for that. Behavioral health records historically separate from physical health records. And that leads to a continuation of stigma, a continuation of poor communication between physical health and behavioral health. You know, if I have a patient that is interested in having sex with iguanas, I don't need to communicate that to the internist, but I do need to communicate that that person has a bipolar disorder and is prone to going on spending sprees and doing all kinds of outlandish things. I should be able to communicate that readily to other people who are involved in the health care of that individual. Behavioral health is not understood by physical health, by the larger society. So it's been seen for a long time as a black hole, and behavioral health did not do a good job of speaking clearly about what it did. For example, heavy use of jargon, soft science, untested hypotheses such as asthma as a cry for help, or the schizophrenic mother, or multiple personality disorder, or recovered memory. And you know, the ideal patient back in the 50s, 60s, was the Yavis patient. How many here know what I'm talking about when I say Yavis? Okay, one or two. So this is the ideal patient from the view of practitioners. So Yavis stands for young, attractive, verbal, insightful, and successful. No wonder the public health sector suffered. And diagnostic fads. Well, we're going through diagnostic fads now, and we've done so for many years. So the first diagnostic fad was the overdiagnosis of schizophrenia. Second diagnostic fad has been the overdiagnosis of borderline personality disorder. A third diagnostic fad, attention deficit disorder. I read it in Cosmo. So from the behavioral health perspective, here are some people that caught my attention. So Paul McHugh was the chair at Hopkins, and he wrote a provocative paper series on psychiatric misadventures and how psychiatry lost its way. And he talked about, well, how many of you think that the DSM is a really important body of work?
I'm scared to raise my hand.
So in the 1970s, the scholars at Washington University, St. Louis, they wanted to address the dearth of research in American psychiatry, and an effort was begun to look at a limited number of well-established disorders such as schizophrenia and mood disorders, and to isolate clear and distinct symptoms that separated clear cases from less certain ones. And by creating such a research diagnostic criteria set, their hope was to permit study to proceed across and among laboratories and free of concern that erroneous conclusions might arise from the investigation of different types of patients in different medical centers. They did not claim to have found the specific features of schizophrenia that would be validity. They were identifying certain markers or signs that would enable comparative study of the disease at multiple research sites, which is a matter of reliability. So I think that what's happened with DSM is that we've made it seem as if diagnosis is a slam dunk. That because somebody fits 5 of this or 3 of that, that means that they have that. And I'm going to push hardly on that concept because I think we do a lot of damage in the process of misdiagnosing because we have not done what should be done in assessing somebody properly. Now, the US-UK study was a harbinger of some of this diagnostic problem that I'm talking about by Kendall. And that was a study where there was a comparison between New York City and London psychiatrists in terms of how they diagnosed. And a scientific group took a number of videotapes of individuals, patients with psychiatric problems, and diagnosed them as a scientific group, and showed the videotapes to the London and the New York City psychiatrists. The New York City psychiatrists diagnosed schizophrenia 7 times more often than the people in London. The people in London, their diagnoses were more closely aligned with the research scientists, basically. So there's been a historical trend to overdiagnose schizophrenia. If somebody's coming in and they're hearing voices or feeling that the CIA has implanted a chip in their brain, that is not necessarily pathognomonic for schizophrenia. The Rosenhan's experiment is kind of an interesting experiment. He took some people without any psychiatric disorders, and they pretended to have psychiatric disorders, and they were admitted to state hospitals. And that's a very interesting study to read. There are issues in terms of methodology of that study, but it gets to some of what I'm saying. And then finally, this fellow, Ken Kendler, he cites a poem by Gerard Manley Hopkins, who was in the Anglican clergy in the area where John Keats grew up, about pied beauty. Glory be to God for dappled things, for skies of couple color as a brinded cow, for rose moles in all stipple upon trout that swim, etc., etc. And he said, there's a dappled nature of causes of psychiatric illness, and we have to replace the organic functional hardware-software dichotomy with empirically based pluralism. And he said, there are 5 categories of biological effects: molecular, neuroscience, aggregate genetic effects; 3 psychological effects: neuropsychology, personality and cognitive attitudinal patterns, trauma exposure; and 3 higher order effects: social, political, and cultural. These 11 components need to go into making a diagnosis. You think about that, how challenging this is to do. Very different from how our residents are trained, which I think we train residents to be good quiz show respondents, as opposed to being good thinkers. So, DSM versus the research domain criteria of Tom Insel, which is based on neuroscience, pathophysiology, and what will evolve from that, what the hope is that will lead to a really more functional and realistic diagnostic process. Right now, and I understand there are a lot of people who worked hard on DSM, but right now what we have is nothing near to what we should have. We need to think in terms of a life chart for somebody coming in, not cross-sectional symptoms. Developmental history, school performance, get along with other kids, that kind of thing. Situational versus long-term issues, stress points, genetic load versus none. Do we accept diagnoses at face value, or do we do due diligence in constructing a diagnosis? And the reason why I'm emphasizing this, we're talking about workforce and workforce reform. Well, the workforce won't reform if what we're doing is not correct. It's easy to say, well, let's bring in a whole bunch of people into Nevada and let's turn them loose because they all have licenses and they're going to do the right thing. I don't think so. Medications and therapy. For how long do we provide medications and therapy? A lot of people who feel that people with low-level depression don't need to be on antidepressants. They can be managed very effectively through psychotherapeutic techniques. What type of medications and what type of therapy? What's reasonable and what's the evidence? How should the patient, client, family be engaged? Is any of this taught? How are people trained? How are people trained to work in teams? What's the quality control? So we can talk about all these models, but I'm interested in the functionality of a team. And is it doing the right thing? And what are its outcomes? And how does that team compare with another team down the block? That's where it really starts to happen. Costs and payments. So the top 1% of patients account for a little over 20% of total expenditures, with a mean annual expenditure of $87,000 per enrollee. And 20% of those individuals, they remain in that category from 2009 to 2012. non-elderly Medicaid enrollees who use mental health and substance use services make up nearly 1/3 of the high-cost enrollees. So the focus is on high-cost, high-need patients. And 60% of these dual-eligible patients have comorbid behavioral health problems. Behavioral health disorders are the second largest contributor to Social Security disability behind musculoskeletal disorders. So the system is rapidly moving from fee-for-service to value-based payments with bundled payment reform initiatives. 30% of Medicare payments are tied to quality and value through alternative payment models by the end of this year, and will be 50% by 2018. And there is certainly a lack of association between spending and quality. Integrated delivery systems that provide strong support to clinicians and team-based care offer great promise for improving quality and lowering costs. So in the same way that clinical systems are integrating and being bundled, do the funding streams from various sources, federal, state, local, private, need to be bundled as well. And recruitment and retention, are we interested in warm bodies, or are we interested in people with organizational perception who can work constructively at improvement? If we are interested in the latter, how first to attract and how second to retain? To attract, there has to be something special. What are people looking for? What will keep them involved? Well, a supportive, responsive, and interesting environment, an opportunity for advancement, a reasonable income, job satisfaction, minimal unnecessary and stupid work, more direct time with patients and families, a system that values innovation, and a system with cutting-edge values. I would want to work in a system like that. Supervision. Routine provision of supervision has declined significantly, and the majority of supervisors have never been trained to supervise. So we have to improve the competence of supervisors and create stronger supervision standards. We have to focus the focus of supervisory functions to ensure quality of care, providing support, promoting professional development, and managing administrative tasks. And we should have in place the development of change management teams that can respond to what the data are and make recommendations for change in that particular organization. And workforce quality of life involves senior leadership having perspective on what's important to change, what is observed in the trenches, what is the feedback coming from the front line, and moving to take action to reduce the burden on the workforce. This is really an essential piece, and that's why care of the workforce as the fourth aim of the triple aim is getting play. Are accrediting agencies open to reducing and consolidating some of the standards? At the state and federal levels, are there things that can be done to simplify the reporting and documentation requirements? Just a plug to the National Annapolis Coalition. In 2017, there will be a piece coming out that will address 7 strategies to strengthen the behavioral health workforce. Now, here's my optimistic piece, okay? Signs of change. Western Michigan and Hofstra have 2 new medical schools, and you're already doing what Hofstra developed. Western Michigan has no basic sciences, no basic science departments. They have 1 basic science department for all the basic sciences because they want to break down the silos and have people inform and communicate. Hofstra, in its first year, has its medical students spending 6 weeks as EMTs, which is what UNLV is going to be doing. IOM, now NOM, I've already talked about the learning health system piece. Their focus is on high-cost, high-need patients. PCORI, Patient-Centered Outcomes Research Institute, it really is about getting away from the randomized controlled trials, which has been the gold standard for research in this country for decades, and saying, well, you know, quality improvement, clinical effectiveness are also important ways for people to contribute to the knowledge base of our field. Iora Health, you have Iora Health in Las Vegas. So Iora Health There's a concierge primary care system. Every patient has an advocate to try to help improve what goes on in the primary care system. Bellin Health is a $2 billion health system in Milwaukee. 60% of the kids have trouble with math and science, but there's a subgroup of those kids that excel. So Bellin Health, the health system, is studying what separates out those kids from the kids who succeed from the kids who are not succeeding. Blue Cross Blue Shield of California, again, these are positive developments, has made domestic violence its #1 priority because it recognizes that that population costs more and has worse outcomes. So it's a financial reason that's driving this change, but who cares, right? It's really important that that's being recognized. HealthShare Oregon, again, a health system in Portland, has made PTSD services a high priority for its members, its health plan. Mount Sinai, and I'm going to show this slide. This is one of my favorite ads from the New York Times Magazine from a year ago, last August. This is Sinai. If our beds are filled, it means we've failed. And they really mean that because it's not about the volume of just filling beds, having the same people come back in again. It's about what are you doing outside of the hospital and the health system to make a difference. Unity Health System in Portland. Now the word about Las Vegas is that this is a highly competitive healthcare marketplace. Unity Health System in Portland, Oregon Health Sciences, Kaiser, Legacy Health, and Adventist have come together as partners to try to disimpact the presentation of people with behavioral health problems coming into their emergency rooms and their inpatient services. So they determined we're going to go at this as partners. Operative word is partners to try to address this problem collectively. California Endowment. Some of you may know the work of Tony Eaton. California Endowment is about a $20 billion endowment. It is taking $100 million and pouring that into 10 communities in California, and I'm going to get to that in a second. And Mass General I'm going to say something about in a moment, and I'm going to go over my time a few minutes. So I don't know what happened to that slide, but basically this slide says your zip code may be as important as your genetic code. Oh, okay. %80 of what influences your life expectancy happens outside of the healthcare system. And Tony Eaton has developed this model showing that basically the medical model accounts for about 20% of that. All the rest is this socio-ecological stuff, social determinants. And we know from the CDC's pyramid that that the largest impact has to do with socioeconomic factors, and the smallest has to do with counseling and education, clinical interventions. And that should give us pause to think about what it is that we're doing, what our society is doing. Now, some of these slides are apparently missing, but Tony Eaton is Canadian, He grew up in Montreal. And this is a scene from Montreal. I think this is the Plains of Abraham. It's probably not as perfect as it looks. And in Canada, there's universal health insurance, universal dental care at age 10, universal child care benefit, highly subsidized post-secondary education, high-quality community resources, parks, sports leagues, libraries, community centers. So Eton went to Hopkins as a medical resident. And the first day there, his chief resident took him around the neighborhood. And this is what he saw. And Tony said, well, what is this? The chief resident said, well, that's just the way it is. This is all Baltimore. And some of you may remember that Time magazine cover. And one thing I wanted to show you was that the cost of sending a kid to school, $9,100 versus prison, $62,000. These are old data. And Eton's thinking is that these neighborhoods are stress incubators that have profound effect on what happens to people, both physically and psychiatrically. So he was a medical examiner in the Oakland area. And Alameda County is this area, this boot-shaped area here. And he started taking a look at what the zip codes were of the people who were in this county. And he showed that race and racism matters. There are health inequities by race and ethnicity. There is a life expectancy by census tract that are easy for people to take a look at. And a 30-year longitudinal study of 7,000 residents showed that those residents with a household income of 1 standard deviation above the mean were 25% less likely to die prematurely. 1 standard deviation below the mean were 35% more likely to die early. And they calculated, well, this is life expectancy by tract, lower life expectancy in the Alameda Hills, Oakland Hills. And if you look at this and compare this, there's overlapping by poverty areas. And this is Alameda County. So there, an additional $12,500 in household income buys 1 year of life expectancy, if you put it into kind of nuts and bolts terms. And the same thing happens in other communities around the country. Total healthcare investment in the US is less. In the economic development countries, for every $1 spent on healthcare, about $2 is spent on social services. In the US, for $1 spent on healthcare, about 55 cents is spent on social services. And this is where we are over here in terms of life expectancy. Western Europe, Japan, and Korea are over here. Now, I know I'm out of time, but I'm going to just kind of breeze through this Mass General stuff for a second. Mass General has made the assessment and treatment of people with substance use disorders its #1 priority. across its entire system. Now, this is a very conservative institution. And why did they take that step? Well, they did an analysis, and part of the Affordable Care Act is that hospitals have to engage with their communities to do something meaningful. Otherwise, there's problems that happen to those hospital systems. And so they looked at Charlestown in terms of heroin overdoses. And substance use disorders were the leading health concerns in the Boston community, in these 3 communities in Boston, over crime and violence, obesity, mental health, environment, education, and housing. This was the #1 priority. 29% of Mass General patients are high-risk Mass General patients have a substance use disorder, and they cost more. So this was the driving force that caused Mass General to determine that it needed to make substance use disorders its #1 priority. And they set up an inpatient, outpatient community system involving recovery coaches, people with the lived experience, kind of working in a bridge clinic where people coming into the emergency room are sent right up to the bridge clinic. So it's basically treatment on demand. All people coming into Mass General who are hospitalized there have this team assess them, even if their primary complaint is not substance use. And the ER visits and the inpatient admissions have dropped. Days reported absent have increased. And there's been a 3/4 day reduction on medicine itself. The length of stay is about a little over 5.8 days or so. They've dropped the length of stay, this is over about 2,300 patients, to 3/4 of a day less than that. So this system is going into all of the areas of Mass General. It's into 16 of the 30 clinical modules at Mass General now, with expansion and integration into the other areas. So I'm going to conclude. I don't know what you're going to take away from my talk, but the slide speaks for itself, I think. Thank you. Okay.
Just a couple questions?
Yeah, just a couple questions, because I know we're past time. I hope I didn't intimidate you.
That's okay, and there'll be time after the
Okay.
break for more
All right,
questions.
good.
Okay, thank you. Thank you, Dr. Huey. He's raised several critical questions about how we train students and what should be the nature of healthcare reform. So thank you for your insights. What we're going to do now, I know we're right up on lunch and the food is here. And so the good thing is that we'll save time and that you don't have to leave and go to the union. The food is already out in the lobby. But I did want you to hear from a couple of our colleagues who are running a substance abuse training project to tell you a little bit more about what we're referring to as SBIRT. And then following their brief talk, we're going to go right into lunch in the lobby. We're asking that everyone please come back by 12:45. And those of you that are in need of CEUs, please be sure to sign back in when we come back for our afternoon session. So we're going to welcome Stephanie Boreen and John Almudine to the stage to talk to us a little bit about the SBIRT project. He'll turn it on
Okay.
for you.
Thank you, Ramona, and Dr. Huey, thank you for that ending. That was a great segue into what our project is all about. So in a effort to save time, I'm going to speak, and John is here as well. So if you have questions afterwards, you can talk to myself or John. On behalf of the Southern Nevada Addictive Disorders Training Project, I'd like to thank both Dr. Sarah Hunt and Dr. Ramona Denby for the opportunity to sponsor a portion of the refreshments today and the opportunity to speak about our project. We're a training and workforce development initiative that began in 2015 based out of the Lindsay Institute here at UNLV. And with Nevada having the second highest rate of substance use disorders in the nation, but the lowest number of providers available to treat substance use, our goal is to facilitate the recruitment and the retention of addiction professionals in Southern Nevada and increase the number of students and professionals who receive specialized training in addictions. One of the ways we do that is by providing training in screening, brief intervention, and referral to treatment for substance use disorders, otherwise known as SBIRT. John Alamoden is a social worker and our community outreach training coordinator, and he can talk to you more about our training. We do have a table outside. If you're interested in learning more about our project or about our SBIRT training, please let us know, and we'd be happy to answer any questions you have. So.
We'll go ahead and break for lunch now and come back at 12:45. Thank you all. Thank you.